Hello.
Hello, doctor.
Hi.
Hello, doctor. Welcome to Anavara.
Thank you.
I'm Harini. I will be the moderator for this webinar, doctor. Nice to meet you.
Yeah, pleasure. My pleasure.
How are you doing, doctor?
All good. Thank you.
And first of all, thank you so much, doctor, for taking your valuable time out for us, doctor.
Yeah, my pleasure. I think it's October, right? Breast Cancer Awareness Month. It's a pleasure to spread the message and, increase the awareness about breast cancer. So where are you all located, Harini?
In Trichy,
In
India,
Trichy.
Tamil Nadu.
Okay.
Is everything ready, doctor? I mean, the presentation and network.
Yeah, everything is ready. Yeah.
Okay. Doctor, we are recording the meeting, doctor.
Okay.
Can you see the screen?
Can you see my screen, Harini?
Yes, doctor.
You can see my PPT?
Yes, doctor.
Yeah, okay.
So shall we start?
Yeah, sure.
So welcome everyone. Welcome to Anavara. Today we are going to talk about breast cancer awareness, such an important topic as you all need to know, especially during Breast Cancer Awareness Month, which is October. As we invite our expert surgical oncologist, Dr.Poovamma, onto the webinar, and I would like to tell you that today's show is going to be very interesting, and you can ask all your questions and queries about breast cancer, and Dr. Ma'am will answer all your questions to you. Do stay with us till the end of the show. So before dive into the show and before I invite our guest for the day, let me thank all of you on behalf of Anavara. Anavara is medical wellness and health facilitator. We provide medical tourism across the globe, providing you with list of hospitals and experienced doctors and also keeping it in your budget. So let's invite today's specialist. Our expert today is an expert oncologist, Dr. Poovamma, who has more than 15 years of surgical experience, including super-specialisation in Oncoplastic Breast Surgery. She is an first graduate of Rajiv Gandhi University of Health Science Program for the fellowship in breast diseases. Her professional experience has spanned across Mazumdar-Shaw Medical Center and Manipal Hospitals, Bangalore. She currently works at Cytecare Cancer Hospital, Bangalore. It's a privilege and honor to introduce Dr. Poovamma. Welcome you, doctor. So it's been a very happy Saturday and a special Saturday. Having you here on the special occasion makes it even more special, doctor. So without further delay, let's get started. Now I'm handing over the session to Dr. Poovamma.
Thank you, Harini, for the lovely words. Yeah, October is designated as Breast Cancer Awareness Month, and I think we should increase the awareness about breast cancer because it's one of the most common cancer in women worldwide, and one of the biggest silent killer of women worldwide. And especially when you talk about India and the African continent, breast cancer is very different here compared to the Western world. A lot of our younger patients have breast cancer, and younger patients tend to have more aggressive variants of breast cancer, which is called as a triple negative variant. And invariably, these cancers are misdiagnosed as, non-cancerous tumors. And a lot of our women come at advanced stages, because of which the long-term outcomes are very poor compared to other women who are diagnosed early. So I think all of us know what cancer is. So what happens is, every day in our life, as our body is exposed to different kinds of injury, there are a lot of cells which undergo changes and they mutate. And when there's a mutation in the cell, the body gives the information to the cell that it should die. But in cancer, what happens is these damaged cells remain in the body. They do not die and they continue to grow. And this leads to cancer formation. So some of the most common cancers are just a minute. Might be, yeah, sorry. So cancer is one of the most leading causes of lifestyle disorder and death the world over. A lot of patients being, wrongly diagnosed, or a lot of cases being diagnosed very late. So I would say it's the tip of the iceberg in most of the Asian countries and in Africa, because a lot of patients get diagnosed at stage 4 breast cancer when the cancer has already spread to the liver or the lung or something else, and they come with either jaundice or breathlessness, and we say, oh, they died suddenly out of a breathlessness, or they had jaundice and they died. And most often it would have been cancer which has which has spread, but we don't know that it was cancer. So the number of cases are really underdiagnosed. So breast cancers are the most common cancers world over. It's overtaken cervical cancer in most places to be the most common cancer. Breast cancer is again a lifestyle disorder. The most important thing many people ask is, why do I have breast cancer? And it's a very difficult question to answer, because, just being a woman, and as you age, it increases the risk for breast cancer. So I would say just being a lady, and as you age, the risk of breast cancer is always high. The next often asked question is, I don't have any family history of breast cancer, so how come I'm here with breast cancer? So this is again a complete myth that you have to have a family history to develop breast cancer. 90 to 95% of breast cancers are not, not related, or doesn't happen in families. It's not hereditary or familial. Only about a small subset of 5 to 10% of breast cancers are familial or hereditary. Okay, so most often there's no family history of breast cancer. Some of the other vague reasons to develop breast cancer is when your menarche or your periods start very young in life, or your periods end very late. Again, that tells us that you've been exposed to hormones for a very long time. That again increases the risk for breast cancer. Obesity is another very important risk factor for breast cancer, and this is something which is in our hands. Many a times people ask, what can I do to reduce my risk for different types of cancers? And obesity is very important, because obesity is a risk factor for so many different kind of cancers, and especially for the breast, it is one of the key risk factors. Another risk factor is hormone replacement therapy for postmenopausal women. Oftentimes during menopause, women develop symptoms of menopause, hot flushes, dryness, and for which they put on hormone replacement therapy. And this again increases the risk for breast cancer. Not having children again is another risk for breast cancer, or having children very late in life after the age of 35 again increases the risk for breast cancer. Alcohol, yes? Okay, again, alcohol consumption and smoking are also other risk factors for breast cancer. There are two things which are protective against breast cancer, and we say the younger you are when you have your first child, gives you protection against breast cancer. And again, breastfeeding is protective against breast cancer. It is said that for every year you breastfeed, the chances of breast cancer decreases by 4%. So it is advocated that a lady at least feeds for 2 cumulative years to reduce the risk for breast cancer. So breast cancer has become not only the most common cancer in the Indian subcontinent, but it's also become the most common cancer in Nigeria. It's overtaken cervical cancer, and nearly 38% of breast cancers in Nigeria the 38% of cancers in Nigeria is breast cancer. The numbers are actually increasing. I couldn't get an exact lifetime risk for Nigerian women, but in India, we say the risk is about 1 in every 22 women develop breast cancer, and the peak incidence is at 40 to 50 years of age. This age group is similar between the Indian women and African women. We've seen that breast cancers in our countries are very different from breast cancers in the Caucasian population. Our women tend to be much younger, but this is again true, holds true to Nigeria too. We tend to see a lot more younger women with breast cancer, and most of our breast cancer, the peak incidence is between 40 to 50 years of age. And another difference is predominantly a lot of our patients have something called as a triple negative variant of breast cancer, which again tends to be a very aggressive variant of breast cancer. So this is again true for both the Asian continent and for the African continent. Our women tend to be younger, and they tend to be, the tumor tends to be more aggressive. The main problem with breast cancer in our countries is that most of our cancers are detected late, and this is the reason our women don't do well. It's not that treatment is inferior in our countries. It's just that in the West, because of robust screening, lack of, because of awareness and robust screening programs which are in place, most of the cancers are diagnosed in the early stages, in stage 1 and 2. But in our countries, cancer is detected predominantly in stage 3, stage 4, which decreases the long-term outcome. So what is important is when breast cancer is detected early, the long-term outcomes are very good. So stage 1 breast cancer has a high cure rate, as high as 96%, whereas stage 2, the cure rates again fall to about 90%. For stage 3, we say the cure rates fall to about 80%, and for stage 4, the cure rates, or the long-term survival dramatically falls to about 20 to 25%. So this is the difference in our countries. It's not that we'd have inferior treatment. Why do our patients do badly? It's because they're diagnosed late, and this is, I think, and this is because of lack of awareness. And I think that's why these sessions are very important to increase the awareness among all sets of people. It's because not just about women, because men too have so many women in their life. They have their mothers, their sisters, their daughters, their wives. So I think information is the key there, and only with information being disseminated out there, we should be able to increase the awareness about breast cancer and decrease the deaths. So this is just about Indian numbers, but what I could get information on the net was that, again, in Nigeria, a lot of younger women getting diagnosed with breast cancer. So that's another age. So we think breast cancer is a disease of the older women. It is not. We are seeing a lot of cancers in younger women, and even in some of them in their late 20s, lot between 30s and 40s, and 40 to 50 age group. So age is really not a criteria. Just because somebody is young, we shouldn't think that this can't be breast cancer and simply reassure them saying this is not cancer and send them. So what happens is they come back to us again after 6 months, 8 months, and by that time the cancer has progressed and become already metastatic breast cancer, meaning to say it's already spread. So that's why I say don't look at age and say, oh, she's too young, she can't be cancer. Have a high degree of suspicion. When you see any women with a lump in the breast, get it evaluated, and only after complete evaluation and ruling out cancer should we reassure them and send them home. So what is the reason why women come late when they have breast cancer? See, breast cancer is a very, very silent problem for a very, very long time. Most often, the only complaint the women would have is a lump in the breast, and this is the most common symptom, a lump in the breast. So what actually brings a patient to the doctor? Most often, when somebody is uncomfortable, they're painful, they come to the doctor because it's uncomfortable. They're in distress. But in breast cancer, what happens is most often there's absolutely no pain. It's just a lump in the breast, not troubling the women at all. And because of this, what they think is, oh, there's something there, but it's not troubling me at all. So why go? And then say, oh, it must be just related to my menstrual cycles, and it'll go away by the next month. Next month it's forgotten. 2 months later it's forgotten, and then 6 months later it's like, oh, this lump is not disappeared, is it? It's still there. Maybe I should get it evaluated, and that's when there's a time lag. Women come in later, much later from the time they've actually seen it. So the take home today would be, the most common complaint in breast cancer is usually a painless lump. Sometimes the lump is painful. Sometimes women might just feel that, one area of the breast feels thickened, feels different, feels abnormal. Sometimes the symptoms could be as vague as, you feel that the nipple is being pulled inwards or pulled towards one direction. It doesn't project out completely. Another way breast cancer could present is you have spontaneous nipple discharge, usually clear water-like discharge. And you'll be like, oh, this is some milky discharge maybe, and nothing to worry. But again, nipple discharge is also a symptom of breast cancer. Sometimes you could just see some color changes on the breast, or you could see prominent veins on the breast, again telling us that it's breast cancer. Very rarely you might be able to say, okay, if this breast feels or looks completely different from the opposite breast. It feels maybe fuller, heavier, bigger. The skin feels very different. It feels very thick. Looks like a peel of an orange. So these are the symptoms of breast cancer. So I would say most common, most important is a painless lump in the breast. Remember that. So why is screening important in breast cancer? So breast is a very, very big organ. It's a conical organ. So what happens is if the lump is superficial, you might be able to feel it early. But if there is a deep-seated lump, it might take quite some time for somebody to detect that there's some abnormality. And usually in this kind of a situation, especially if the lump is very deep-seated, the women might say, I didn't notice any lump at all. It's just that gradually I started to notice that, this breast is feeling heavier, fuller, no pain at all still, but the skin started to look very abnormal, different. And that's when they come to the doctor. And usually by that time, it is a stage 3 breast cancer. What we advocate for all women is that, they should be aware of what their breasts look and feels like. This is very important. It will help us to pick up cancers way early, even if mammograms are not available there. So we advocate that, once a month, typically after your period is over, examine yourself, look at yourself, stand in front of the mirror, look at yourself, with the hands by the side, with the hands, raised above. Look for any subtle changes in the dimpling, subtle changes in the breast, any kind of a, a bump or a lump-like thing on the breast. Look to see how the nipples are. Are they pointed outward? Are they projected outward? Are they being pulled to inwards? Or are they being pulled towards one side? Any kind of obvious skin changes. And then lie down, because the breast flattens out by that way. And using the flat surface of your fingers, gently rotate on the breast and look, feel the breast for any kind of a lump, any kind of a thickening, anything which feels abnormal. And gently squeeze the breast to see whether there's, gentle, I'm not saying like a huge squeeze, gentle squeeze to see if there's any nipple discharge. Ideally, we recommend that, this is being done every month, once a month. And with regular self-breast examinations, women learn to identify what their normal breast feels like. And by doing this regularly, we would, be able to identify tumors a lot earlier than somebody who's never done a self-breast examination and suddenly just one day wakes up to feel something in the breast. So again, to reiterate, when you're doing a self-breast examination, look for any kind of a lump in the breast, any kind of a thickening in the breast. Do this at least once a month, and it will help us. So this is just a diagrammatic picture to show you what happens when women do self-breast examination regularly, compared to they do it once in a while, compared to what is the size of tumors picked up when we do a mammogram occasionally, compared to when we do a mammogram regularly. So what happens is when somebody knows how to look, has regularly done self-breast examination, the size of the tumor picked up becomes smaller. With an occasional mammogram, again, without having any symptoms, smaller tumors are identified. But when mammograms are done regularly, we can identify very, very early stage breast cancer, tumors as small as 5 millimeters, 1 centimeter, which otherwise, it'd be just impossible to feel it. And when we identify these small tumors, the stage of diagnosis comes down to stage 1, and the stage 1 tumors have excellent long-term outcomes. I think there's always this myth that, when I'm fine, why do I need to go to the doctor and bring trouble on myself? So mammograms do not cause cancer. It helps us to identify cancers early and detect tumors in stage 1. Often, one of the questions asked is, what can I do to, identify cancer early, pick up cancer early, or, how can I prevent cancers? So there are some things obviously we can do to prevent cancer, but mammogram is one of the few, breast cancer is one of the few cancers where we can do tests to identify the cancer way before the lump is felt by a woman. That's why it's called screening, meaning we examine the breast, look at the breast, even though the woman doesn't have any complaints, to see whether the breast is completely normal or is there a small tumor lurking there, so that we can identify it early and pick it up early. So when we say screening, what we would say, all women, please be aware of your breast. Do self-breast examinations regularly, will really help you to identify tumors early. For women less than 40, we would say if there's any, If you feel anything suspicious, please come in for a clinical breast examination, and an ultrasound is what we would recommend. For all women above 40 years of age, we would say do a clinical examination and a mammogram. And some people might have a question, why clinical examination and mammogram? Very rarely mammograms can miss tumors. About 10% of tumors can be missed on mammograms. And that's why clinical examination is very important, because on a clinical examination, you'll be able to feel and identify which area is abnormal. And then we do a mammogram, and if this says, if the mammogram says it's completely normal there, we can add on ultrasound. Or if the clinical data is very, very suspicious, you can also do something called as an MRI of the breast. That's why a clinical examination and a mammogram kind of go hand in hand to identify cancers early. Again, to reiterate, regular screening helps to detect cancer early, way before the women would even realize that there's something lurking in the breast, and this will improve our long-term outcomes. So now mammograms, again, with technology improving dramatically world over, we've moved away from the 2D mammograms to a 3-dimensional mammogram or a tomosynthesis. So a mammogram is typically an X-ray of the breast. The breast is squeezed between 2 glass plates, and an image is taken. So in a 2D mammogram, we only have a 2-dimensional image of the breast, and that's the information we get. What is different in a 3D mammogram is that in a 3D we get pictures at 1 millimeter cuts of the breast, and increases the accuracy of detection of tumors, especially for younger women who have very dense breast tissues. So if you see the mammogram on top compared to the mammogram below, you would see that the top one has it's a gray and white kind of a shadow with predominantly gray. So that's typically a breast of an older woman, which has more fat and less breast tissue. The mammogram below, which is seeing dense snow white kind of an appearance, is the mammogram of a younger woman. So again, the breast is made up of breast tissue and fat, and younger women tend to have more breast tissue compared to fat. So breast tissue appears white on the mammogram. So younger women, white cancer on the background of white breast tissue, tumors are very easily missed. And that's why for younger women, we always would say, usually we don't recommend mammograms before the age of 40 for younger women, because this is the reason. But if somebody has been diagnosed with cancer, then obviously we do a mammogram because it gives us some other additional information. That's why for younger women, we would say go in for a 3D mammogram. It increases the accuracy of detection of cancers. So this is again showing you the same thing. This is a 2D image on the left side and a 3D image on the right side. So on a 2D, if you look at it, doesn't look very suspicious. It looks like normal breast tissue. But on a 3D, when you look at it at 1 millimeter cuts, you see it is a growth. You can differentiate and say it is a growth over there. So once somebody comes in with, say, a lump in the breast, or mammogram has picked up something abnormal, we would usually do an ultrasound also. If we feel the information acquired with these tests is inadequate, especially for younger women, or when it looks like there are multiple tumors or there's very early stage breast disease, we also add on an MRI breast. We don't do a directly MRI breast, because MRI breast can throw up a lot of information which can be, false positive, false negative. So MRI is always done after we do a mammogram and an ultrasound. For diagnosis, biopsy remains the most important gold standard, where you put in the needle and remove pieces from the lump and send it for testing. For very small tumors which are not not seen on ultrasound, or not felt, seen only on a mammogram, we do something called as stereotactic biopsies. We can do something called as biolocalization for these very small tumors. Once the cancer has been diagnosed, we also do something called a staging test to know what is the stage of this cancer. Is it a stage 1 cancer? Is it a stage 2? Or is it a 3 or a 4? Because treatment will vary depending on the kind of stage it is in. For a very small subset of patients who have a strong family history of breast cancer, or very young women with a triple negative variant of breast cancer, we would advocate doing also genetic tests to see whether this tumor is genetic in nature. So this is just showing us how a stereotactic biopsy is done using the mammogram machine for very small tumors to target very, very small lesions. This is again a procedure where we have biolocalized the lesion. Many a times when you have picked up tumors which are very small on mammogram and you can't feel it, right? So how do you go and operate where to to increase the accuracy? It shouldn't be that we'll end up sacrificing the entire breast because we want to remove a small tumor, but we don't know where the tumor is located. So for these, we use something called a stereotactic biolocalization or radio-occult lesion localization, and go and target only the cancer tissue and remove that, and then again do an X-ray of that and prove that we've removed the tumor and saved the breast. So breast cancer is not one disease. We have, treatment is very much individualized to the patient, to what stage it is, what kind of subtype of breast cancer it is. We do a molecular classification and then only treat it, because it tells us, how aggressive the tumor is, what kind of drugs will work, what will not work for that patient. So again, I would one of the problems we are facing both in India and in Africa is we're having a lot of younger women with breast cancer, and our incidence of the aggressive triple negative variant of breast cancer is much higher compared to the Western population. So in the West, they say a triple negative breast cancer is in about 20 to 25%, about 15 to 20%. But in our population, the incidence of our triple negative breast cancer is slightly on the higher side. Between 20 to 25 to 30% is triple negative variant. Cancers are always best treated at a specially designated oncology unit because cancers require multidisciplinary treatment. It's not just the surgeon working, or it's not just the the medical oncologist or the radiation oncologist. It's a teamwork of surgeons, medical oncologists, radiation oncologists, the radiologist, the pathologist. All of them are involved from the time of diagnosis to complete treatment. Many a times women, kind of tend to compare and say, okay, I have had surgery, somebody else had only chemotherapy, somebody else had only, hormone therapy. So why is it that sometimes treatment varies across single entity called breast cancer? So again, here the stage and the molecular subtype is important. Most often for stage 1, stage 2, and stage 3 kind of breast cancer, we will have a component of surgery, chemotherapy, plus or minus chemotherapy, plus or minus radiation therapy, and hormone therapy. So usually it's a multi-modality way, with multiple modules we treat the breast cancer. It's not just one. So again, I told you that, treatment is individualized to the patient. We've done so, science has moved so much ahead. It's not that toxic treatments are given to everybody. Depending on the stage and the type of breast cancer it is, we tailor the treatment to fit that individual. One of the most, again, common asked thing, in OPD is that, you have a tumor in the breast and we're removing the tumor after surgery. Why is it that, we need to give additional chemotherapy or, other forms of treatment? So breast cancer, what we say is, it could be metastatic even at the time of diagnosis, though it's not growing anywhere. You can have cancer cells in circulation, which are not growing, which our own immunity kind of kills. But many a times individual cancer cells remain silent, dormant in other organs, and by giving systemic therapy in the form of either hormone tablets or in the form of chemotherapy, we're increasing the cure rates of cancer and decreasing the incidence of a relapse. And that's why this additional treatment is required for breast cancer. Having said that, what can we do to reduce the risk, or reduce our risk of developing breast cancer? Like I already told you, obesity, cut down on your obesity. Obesity is one of the key risk factors for breast cancer. Have children, have them young. If you're breastfeeding, feed for a longer time. If you consume alcohol, cut down on your alcohol. If you're someone who's receiving hormone replacement therapy, please talk to your gynecologist and come off hormone replacement therapy, because this is something which is proven to increase risk for breast cancer. Exercise is very, very beneficial. It prevents breast cancer, and for certain types of breast cancer, it is also proven that 30 to 40 minutes of exercise 5 days a week can reduce the risk of relapse. this is, I've put this slide because 30 to 40% of all cancers are lifestyle related. It's related to what we eat, what we drink, how active we are, how good is our sleep, how do we manage our stress. And obesity is one of the biggest killers for cancer. It is said that obesity can cause so many different kind of cancers, starting from brain tumors to tumors of the bowel, kidney, gallbladder, stomach, liver, uterus, certain types of blood cancer. And it's said that nearly 1 in every 20 cancers is linked to obesity. And this is something which we can do. And I think obesity is becoming very, very rampant all around the world. And this is something which is in our hands and we can do. So a healthy diet and regular exercise, again, very important. Good sleep, again, is very important. Maintaining our circadian rhythm, meaning to say the sleep and wake up cycle, having a good night's sleep and waking up early, sleeping early is again very good to reduce the risk of all kinds of cancers. So there's a lot of healthy diet which is out there. Cancer fighting diet, it usually includes all the green leafy vegetables, the berries, your citrus fruits, dark chocolates, mushrooms again are very, very important, cancer fighting. Cut down on alcohol, cut down on smoking, cut down on processed meat. Processed meat again is a class 1 carcinogen for different types of cancers. So be careful about what is on your plate. Is very important because that's how you nourish your body is very important. So some of the myths about breast cancer, one of the often asked question is, can I wear an underwire bra? Can I wear a black bra? If I don't wear a bra, will it increase? Or can I wear a bra in the night? Or if I remove the bra in the night, does it, cause cancer? There's absolutely no association between breast cancer and the type of bra you wear. That's a complete myth. Then again, people have this misconception that, mammograms are dangerous or, regular mammogram can prevent cancer. No, regular mammograms can identify cancers early. It doesn't prevent cancer. And the radiation exposure with a mammogram is very, very minimal. I would say the benefit is way more than the amount of radiation we get exposed to. Then the next common myth is, does breast cancer run in the family? Like I said, only 5 to 10% of breast cancers are genetic, or 90 to 95% it's non-genetic, and it doesn't run in the family. Again, that thing, people think, if you find a lump in the breast, it means it has to be cancer. No, especially for a lot of the younger women, we have a lot of non-cancerous tumors in the breast. Every lump in the breast is not a cancer. But what I would say is every lump in the breast has to be evaluated and cancer has to be ruled out. Again, another thing is, I think many people think, I'm too young to have cancer. Only women above 50 will get cancer. Very, very untrue in our countries. We have seen women as young as 22, 23 with zero family history coming in with breast cancer. So I would say any girl with any change in the breast has to be evaluated. So recently we were all joking, one of my colleagues was telling me, I've heard you talk so much about breast cancer soon, I'm going to start doing self-breast examination. So I said, why not? It's not that men can't get breast cancer. Men too can get breast cancer. But yes, obviously it's very uncommon. But it's said that 1% of breast cancer can occur in men. So men too, I would say the information is, the treatment is the same, the staging is the same, but men too can develop breast cancer. So as a man, if you've noticed something different in your chest, in your breast, please do get it examined. There is absolutely no association between deodorants, antiperspirants. A lot of studies being done about that and the increase in breast cancer, but absolutely no proof about that. Sometimes a question asked is, after a mammogram or a biopsy, can it, increase the spread of cancer? No, that's been disproven completely. Again, size is not a criteria at all. It's whether you are small-breasted, big-breasted, medium-sized breasted, any women can develop breast cancer. Size is really not a criteria. Does carrying a cell phone in your bra cause cancer? This is very common in our country. A lot of women carry their phones there. But again, very true, not proven at all that cell phone, in your bra can increase risk for breast cancer. Another thing, most cancer patients will come and ask us, since I've been diagnosed with cancer or, whatever, does it mean I have to completely go off sugar? And the answer to that is really no. What we would say, everything in moderation is fine. Consuming no sugar at all is not going to cure you of cancer or decrease the risk of cancer. Obviously, excess sugar is not healthy, can increase the risk, but it doesn't mean that, you can't consume sugar at all. Again, another thing is people think the only way a breast cancer can present is lump, but I've told you there are a lot of other unusual ways breast cancer can present, as nipple discharge, nipple retraction, nipple being full towards one side, just a little kind of a thickening in the breast, any just prominent veins, the entire breast just feels heavy and large, can also be symptoms of breast cancer. Again, I told you breast cancer is not pretty much treated the same way. It depends on the stage of the tumor. It depends on the subtype of tumor it is. Another common myth, especially for younger women, is, oh, I have a lump and it's painful, right? So it 100% is not cancer. So I would say, maybe for 100 patients with breast cancer, I would see maybe 3 or 4 would complain of pain. So just because it's painful, it doesn't mean it's not cancer at all. Like I said, every tumor in the breast, any lump in the breast has to be evaluated. Does trauma to the breast cause cancer? Absolutely not. Trauma can lead to a formation of a lump in the breast, and that's called as fat necrosis. That's because of breakdown of fat because of trauma, and there's calcium deposition along with that, and that leads to fat necrosis and a lump, which can feel hard and kind of resemble a cancer when you see it from outside. But with mammograms and biopsies, we can completely disprove that it's fat necrosis because of trauma and it's not cancer. Next other thing, many times people tell me, I breastfed my child for so many years, so how can I come with cancer? So breastfeeding is protective to a certain extent, but that doesn't mean that just because you have breastfed, your risk of breast cancer is 0. That's not true. So breastfeeding can help to decrease the incidence of breast cancer, but not completely prevent. Again, another question is, if somebody is pregnant, that means it can't be breast cancer, right? Very uncommon again, but 1 in every 3,000 pregnancies can lead to breast cancer. So any tumor in the breast which is detected during pregnancy has to be evaluated, and any solid lump detected, cancers have to be ruled out. Is breast cancer contagious? Often asked. We have grandchildren at home, we have small children at home, so is that a problem? Absolutely not. Breast cancer is not contagious at all. There's absolutely no problem with mingling with a person who has breast cancer. Does breast implants increase the risk for breast cancer? Again, completely disproven. Enough data out there saying breast implants do not increase the risk for breast cancer. Does breast cancer occur only after menopause? Again, a complete myth. We have women as young as in their 20s who develop breast cancer. So really, menopause is not a criteria at all. So the take-home message I would today say is anybody can develop breast cancer. As you age, the risk to develop breast cancer increases. In our continents, young women have a lot of young people, young girls have breast cancer, and the degree of suspicion in these younger population is very, very minimal, because we tend to think that it's related to menstrual cycles, and women are also so busy with career, families, that they kind of tend to ignore their health, and they think it's just related to your cycles and keep putting it off, and finally after a few months together, they wake up and come to the doctor. And young women tend to have, again, aggressive breast cancer, so delay makes a huge difference in long-term outcomes. So I would say take your health very important. Women form backbones of their family, and if they're sick, the whole family comes crumbling down. And we don't want women in the peak of their the most productive years, 30s, 40s, 50s, coming down with this disease and having bad outcomes because of lack of awareness, or delay in diagnosis, wrong treatments, inadequate treatment. So be aware what are the signs and symptoms of breast cancer, and at the first instance that you see something abnormal, feel something abnormal, go in for a test. advocate screening for early detection. So, Nigeria is one of the few, Lagos is one of the few places in Nigeria where screening has become mandatory. It's driven by your government. So, there's a structured screening program driven by the government. Please make use of it. And even if you don't make use of a government-driven breast, a screening mammogram program, just a mammogram per se is not a very expensive test. And I think this is something we have to acknowledge. And maybe give it to yourself. I know one of my colleagues, she tells me that every year on her birthday, before she goes home and cuts the cake, she and her friends go in for the mammogram on her birthday. That's a standard for them. So okay, it's this Dr. X's birthday, the three of them will go get their mammograms in the morning, say yes, everything is fine, and then go celebrate the birthday. I think and that's an excellent way of keeping in check and keeping, saying that health is important and we have to make time for our health. So if there's any questions, I would be glad to answer them.
Yeah, thank you, Doctor. Thanks for taking the time. I am Ashok. I'm also from Anavara. Doctor, at what stage do you recommend a lady to go in for a mastectomy?
So, see, whether we decide to save the breast or we do a mastectomy is completely dependent on the kind of tumor, what's the extent of tumor. It's not that every breast cancer warrants a mastectomy. In many of the cases, we can save the breast. It's only when the tumor to breast ratio is very high, it's very less. Meaning to say, if you have a big tumor in a small sized breast, or you have multiple tumors in the breast, which are not, located in one particular area, but spread out in the breast, or in a stage 3 breast cancer, where because of cancer, we see skin changes, skin involvement with tumor. That's the only time we would recommend a mastectomy. But for smaller tumors or a big breast with a marginal sized tumor, only single tumors, not multiple tumors, we can easily save the breast. And the number of breast conserving surgeries you do to the mastectomies you do is actually an indicator of how good the unit is in treating breast cancer. So if a unit is only doing mastectomy, it means the quality is not great in the unit. So it's not that every breast cancer warrants a mastectomy. It's just that after we conserve the breast, radiation therapy to the breast becomes mandatory to prevent a second tumor from arising. So it's not that every breast cancer means mastectomy. Even for women who need mastectomy because the tumor is extensive, or you have skin involvement, or you have extensive stage 0 breast cancer which requires a mastectomy, we do provide immediate reconstructive options to them. There are multiple ways we can reconstruct the breast, and this is something which is, the options are always given to the women, where we can do the cancer surgery and the reconstruction at one sitting.
Oh, thank you very much, Doctor. You brought up the second topic that I was going to ask about. That is about the reconstruction, because I have a client now who is interested in reconstruction for his wife. So, well, as Harini said, we are globally located. I did get options from Spain, Turkey, and Dubai. But India being too far away, it's about like 12 hours time difference. But we can give them an option of India also. What is the time that is required for reconstruction, and how realistic will it be?
So the best kind of reconstruction is usually immediate, when it's done immediate, because many a times we can save the skin cover in the breast itself, and when we save the skin of the breast and remove the tumor, you can get very, very good reconstructive appearances. Again, I think this depends on the kind of reconstruction we do. Are we doing an implant-based reconstruction? Are we doing a partial reconstruction or a whole breast reconstruction? What kind of reconstructive technique the patient is, happy with? Like I said, you have something called as the silicone-based reconstruction, and you have your own tissue-based reconstruction. We can use something called as a DIP flap, and we take tissue from the abdomen to reconstruct, or a free flap. Gives excellent cosmetic outcomes. We can also use tissue from the back to reconstruct. It depends on many factors, but many a times we can give them very realistic, good outcomes with reconstruction.
Okay, doctor. If the patient is interested, can I set up a meeting with you?
Yeah,
probably
definitely.
next week or so?
Sure. Yeah, we can give them the options.
Okay. Okay. Thank you, doctor.
Thank you, doctor. It's really a neat and crystal clear presentation. And folks, you have any questions, you can raise your hand and ask one by one. Yeah, Famida.
So, hello, doctor. I'm Famida from Anavara. So now there are so many options, treatment options available for breast cancer. So I just wanted to know what will be the side effects of each treatment option, doctor?
Okay, so surgery, the side effects would be for some time you'll have little pain, maybe a little bit of discomfort. Another things is this extensive lymph node dissection. You can have swelling up of the hand. That's from surgery or lymphedema. See, from chemo also, again, there are a lot of side effects like hair loss, skin changes, nail changes, skin darkening, fatigue, feeling very tired, nausea, vomiting. But most of these side effects tend to be there while on treatment. Okay, once the treatment is over, all of them kind of gradually disappear. Hair will completely come back. Skin and hair revert back to normal with time. Obviously, fatigue is there for some more time after completion of treatment, maybe 6 months, and it depends. But those are the common side effects. Radiation, again, is for the breast is very well tolerated most often. Maybe some local skin changes, local skin darkening, maybe a little burning there, again for some time, and then it goes away.
Thank you so much for answering, doctor.
Doctor, will my breasts look and feel differently after breast cancer surgery?
So yes, the look will depend on the kind of surgery is done, whether it's been aesthetically done or not. Okay, because you can do very good aesthetically, saving the breast, and the looks can be nearly equal there, and mixed with scars which become dull with time. The feel of the breast again feels a little different immediately after surgery, and especially after radiation therapy. It tends to feel a little heavier, thicker, the skin feels thicker. But with due time, all of it goes back to normal. You just have to give it time, sometimes 6 months, sometimes 1 year, and gradually it reverts back to normal.
Okay, doctor. Thank you, doctor. Ramya, do you have any questions?
Yeah, I'm Ramya from Anavara. How can I lower my chances of getting breast cancer, ma'am?
So like I just told you, get your body weight to within your normal BMI, exercise regularly, absolutely no to alcohol, smoking, be physically active, 30 to 40 minutes of exercise at least 5 days a week, good sleep, a lot of greens in your diet. If you're breastfeeding, breastfeed for at least 2 years. Planning to have a child at a younger age. These are the things which you can do to reduce the risk for breast cancer.
Thank you, ma'am.
Does anybody have questions?
I just want to point out that Cytecare is a specialized oncological hospital, specialized hospital. We have used Cytecare. I don't know how many outsiders have joined. I have not just checked it. But Cytecare is a specialized oncology hospital. We have seen excellent results. They are highly focused on cancer. And also, once the cancer therapy or the treatment is done, they also give very good counseling. So as doctor pointed out initially, treatment of cancer is a specialized thing, and going to a specialty hospital is advisable.
Yeah, I think cancer, it's not just about the physical treatment of the cancer, but it's also, looking into the mental well-being of the patient, mental well-being of the caregivers. Also, we tend to completely forget about caregivers, I think, during cancer treatment, because all the effort is put on the patient. But I think the caregivers also go through a very, very difficult time. So having access to mind and body, a holistic approach where, caregivers also can receive psychotherapy if required, and counseling to to, hold hands during treatment is very important. So we've had something called as cancer navigators in the hospital. So these are people who have actually had cancer by themselves and, cured and doing well now. So they kind of volunteer with us. They just talk to patients, talk to caregivers at the time of diagnosis, during chemotherapy, and just sort out small issues for them, which patients might find it a little difficult to come and, approach a doctor and ask, some silly things. So I think having access to those kind of people in the hospital also makes it easy for them, to clarify small doubts, and, just maybe sometimes just having someone to talk to, and having someone who's gone through the process themselves and understand, you feel like, okay, they'll understand you way more than somebody who's not gone through that, helps put the patient at ease.
Thank you, Doctor. Yeah.
Anybody have questions? Okay, thank you, Doctor.
Yeah, pleasure.
We are really glad that you could take time out and conduct the much needed webinar on breast cancer. And also, I thank the participants for attending today's webinar. If you want to consult any doctors, you can contact Anavara. We are encourage you to connect with us on social media. And if you have any additional questions, you can contact us by email or telephone. We are happy to provide you additional support. Thank you. Thank you, everyone.